Hi, Monty Pal here on behalf of GU Oncology Now. Today we're going to be talking about updates in kidney cancer with three of my dear friends. We're going to start with a quick round of introductions, beginning with you, Cristina.
Hi, I'm Cristina Suárez. I'm a medical oncologist at Vall Hospital in Barcelona, Spain.
Dan?
Hi folks, Dan George from Duke. I'm a GU medical oncologist and happy to be part of the panel.
Awesome. Brad?
Yeah, and I'm Brad McGregor, also a GU medical oncologist from Dana-Farber in Boston.
Awesome. All different parts of the world here. Monty Pal from Los Angeles, California, and we're going to dive right in. So let's say we've committed to starting our patient frontline on TKI-IO. The practice that I'm seeing a lot is the patient might go through one or two additional lines of therapy, perhaps with a TKI, perhaps with TKI plus IO again, and then receive Nivo-Ipi on Rechallenge. What do you think about that, this phenomenon of rechallenging with Nivo-Ipi in the third, fourth, fifth line setting?
So if I could do it.
If you could do it, if you could do it. Yeah.
Also the data, we have the fraction data for this, for Nivo-Ipi, and the data are not very, very exciting. So the overall response rate, I think, is around 15% or something like that. So, and with no patients showing complete responses. So I don't know about that. I think that for me, a key question is what you mentioned. It's the trials that ongoing trials, we have the CONTACT-03 trial and TNIVO trial, are using immunotherapy after immunotherapy without the stopping. But this will not answer the question on rechallenge with immunotherapy. And we know from many other treatments that it's good if you stop using the same target and then you use it again. So I think that the trials will answer. If they are positive, that's nice, and they will, okay, we need to maintain the immunotherapy. But if they are negative, as you mentioned, I think it doesn't mean that you cannot retreat the patients with immunotherapy in the future in third or fourth line.
Right.
To that point, the trial designs are different. So CONTACT-03, you have to have IO as the most recent line of therapy, and you go on to cabo with or without atezolizumab. But TNIVO-2, actually, you just had to precede immunotherapy in the past. But you do not have to have immunotherapy as the most recent line. So if you had immunotherapy and IO, you could go to TKI and then still enroll in TNIVO-2. So it's a little bit different in that design. So to Dan's point, I think there's almost two different populations in TNIVO-2, right? We're going to have that continuing IO approach, or there's going to be those patients that have a break in therapy.
I'm not sure. I think they did amendment now, and you need to come from the immunotherapy or something like that. You're only allowed now to
two lines of therapy.
To have patients like, and there are some other trials like the Umbrella 03B trial that it's not going to give any answer because it's a multi-arm and it's not a phase 3 trial, but we'll give you some clues. And in this trial that you are using LEM-PEM, but also different targets as belzutifan, LAG3, CTLA-4. And in this trial, you don't need to come directly from the immunotherapy. So I think that it will not give any answer, but some clues about